What causes myeloma bone pain?
Most of the patients have multiple myeloma bone pain due to lytic lesions. We know that myeloma cells express cytokines, proteins that activate osteoclasts. The osteoclasts are the bone-eating cells. You have in your body osteoclasts, bone-eating cells, and osteoblasts. Those are the bone-producing cells. So in multiple myeloma, we know that the myeloma cells directly secrete little proteins, cytokines, growth factors that, again, as I said, activate the osteoclasts, but inhibit at the same time the osteoblasts. So what you end up is that you have a hole in your bone. We call that lytic lesions. And this is because the overactivity of the osteoclasts, of the bone-eating cells, really cause that excessive resorption, destruction of the bone. You can have larger lytic lesions up to a centimeter, several centimeters, but those lytic lesions can be very small. So the presentation of bone disease can vary from just an osteoporosis with many small, I would say, holes in your bones, to a large lytic lesion that can cause a fracture. So usually when you have osteoporosis, you will not really feel any bone pain. But when those lesions become larger, they can be painful. And when you develop a fracture, for instance, very often in your spine or in your ribs as a first symptom, those lesions are very painful. And very often patients come to the doctor with those fractures and with bone pain. As I mentioned, patients who have larger lytic lesions, those lesions can directly cause bone pain due to instability of the bone, and also the myeloma cells can cause directly pain if you have a large accumulation of myeloma cells in the bone.
How can bone pain be managed?
So if patients have myeloma bone pain, the best thing to do is really to treat the myeloma as effectively and as aggressively as possible. So because it's the myeloma cells that are then impacting the bone cells. But beyond that, then it's really important to try to stabilize the skeleton as much as possible. The way that's been most effective thus far is to try to slow down the activity of those scooping out cells. And there's medications which we call anti-resorptive medications. So they stop the bone resorption that's ongoing. And there's two classes of those medications. The first are the bisphosphonates. So medications like pamidronate or Aredia, or zoledronic acid or Zometa. The way that these medications work is they get infused and then they circulate around in the blood. They ultimately land on the bone, and then when they land on the bone, then these osteoclasts try to dig up and scoop out some bone, and in doing so, they take up some of this bisphosphonate into the inside of the osteoclast. They internalize them, and there's an enzyme within the osteoclast called farnesopyrophosphate synthase. These bisphosphonates cause that enzyme to be blocked. And when that enzyme is blocked, then the cell basically can't survive anymore. The other medication that has now been approved now for about the past year and a half is a medication called denosumab or Xgeva, and that works a little bit differently. So in order for an osteoclast to become an active bone resorbing cell, it has to go through a maturation process, and this medication, denosumab or Xgeva, it blocks the signal that the pre-osteoclast needs to become an active osteoclast. That works very well, but the problem is that if you ever discontinue that signal, then all the precursor cells that are built up are then rapidly able to become active osteoclasts, and then they're able to quickly cause bone to be chewed up and lost, and then there's really nothing to stop them. So that's why if patients are started on a medication like denosumab or Xgeva, it really needs to be continued, probably given at least once every 6 months thereafter. Whereas the bisphosphonates, even after you have stopped taking them, they're still lining the surface of the bone, and so they'll continue to be active for several years likely thereafter.
In multiple myeloma, you want to treat A, for the destruction of the myeloma cells, and B, you want to inhibit the activity of the osteoclast, the bone-eating cells, to decrease the bone destruction, bone resorption. And bisphosphonates, that has been shown, help to reduce the activities of the osteoclast. So that's why each myeloma patient who starts treatment for multiple myeloma, independent, and that's important, independent whether the patient has lytic lesions or not, should be on a bisphosphonate and start with this kind of treatment. We have a newer kid on the block, denosumab, which is a rank ligand inhibitor. And denosumab is very conveniently given. It's given as a subcutaneous injection, and in contrast to bisphosphonates, bisphosphonates are given as an infusion. So denosumab, a rank ligand inhibitor, also called Xgeva, is given subcutaneously, monthly, and the nice thing is you don't have to check the renal function. So independent whether you have renal damage from the multiple myeloma to your kidneys, you can get the denosumab. The problem with denosumab is it's very expensive. And usually as a standard of care, we recommend still Zometa. But for patients who have renal impairment or renal problems, I think denosumab is a very nice alternative. What I also want to mention, and this is a very new result, and it was published at ASH last year, that in a large randomized trial with 1,700 patients, in which the patients were randomized to either receive Zometa or denosumab, there was a 10.7 months increase in the progression-free survival in patients who received denosumab. We don't know exactly the mechanism of this, but it's a very surprising and interesting result. And I think in the future, the myeloma experts have to think about what is the best treatment for bone disease. Is it a bisphosphonate or is it denosumab?
Bone pain is a very severe issue, and especially at newly diagnosis of myeloma. There are several things that we can do. Of course, pain medicine should be used. We don't like the non-steroidals like ibuprofen, diclofenac, because they go through the kidneys, and in myeloma patients the kidneys can be involved. So we rather recommend acetaminophen, which is Tylenol, instead of these other drugs. We recommend opioids if necessary. For systemic treatment, also is bisphosphonates and denosumab, because they provide also some pain relief sometimes. For local treatment, we can do either radiation, in the spine, we can do kyphoplasty or vertebroplasty, because the bone cement that is going into the bone there can kind of help to numb the bone in this area, because when it becomes hard, it cooks the nerve endings more or less. And so there's less pain in this area. If necessary, sometimes outside braces help to stabilize so that the patient doesn't do movements that could cause pain. So we have a lot of options to help with bone pain, and still there's a lot of bone pain, and we still have to get better, but I think we already have a lot to help the patients.